Good evening, Namaste. Welcome to this CCI webinar. Greetings from Chess Council of India. Every week after week, we have a wonderful webinar series with the various topics. There is no repetition at all. This is the beauty of the Chess Council of India weekly webinars every Thursday. So I am Dr S Jayaraman, consultant pulmonologist from Apollo First Med Hospital, MGM Healthcare, Billroth Hospital, and I have my own Sri Jayam Chest and Sleep Clinic in Amjikarai, Chennai. First of all, I thank the Chess Council of India leaders, Chairman Trustee Dr. N.H. Krishna Sir, Co-Chair Dr. Narayan Pradeepa Sir, CCI President Dr. Ashish Dubey Sir, CCI National Secretary Dr. Anil Maske Sir, CCI Webinar Coordinator Dr. Vijay Kumar Chennam Chetty, and the architect of this CCI webinar, Dr. Atri Gangopadhyay, Dr. Shivani Swami, Dr. Kirat, and today's the EBUS course directors, Dr. Ravi Ashok Doshi from Indore and Dr. Jaykumar Mehta from Ahmedabad, and all the leaders behind the Chess Council of India working hard every Thursday, nearly about 6 years. This is the 6th year. So wonderfully designed such a way that various topics, various series of webinars. So today is the CCI EBUS webinar series part 2. Last Thursday we had a wonderful to start up webinar, EBUS, why, when and when not, by the eminent faculties and the moderators. Wonderful take-home messages. When to refer a case of the case for EBUS, what are the guidelines, etc. We discussed last Thursday. Today we'll be discussing about the mediastinal anatomy for EBUS operator. Anatomy made procedural, not textbook. This is the topic we'll be discussing in detail. So you all know very well, the mediastinum is the central portion of the thoracic cavity. So both sides lined by the pleural sacs or both lungs. It has a lot of major structures like heart and major vessels like aorta, SVC, pulmonary artery, IVCs, and lymphatic channels, lymph nodes, thymic tissue, lot of tissues, neural tissues in the posterior mediastinum. So mediastinal anatomy, so mediastinum divides into superior and inferior. And inferior mediastinum again divides into the anterior, middle, and posterior. We have a lot of important structures. So anatomy is a paramount important. So majority of the mediastinal lesions are incidental findings. Suppose we ask for a master checkup or a visa employment checkup. So routine chest X-ray for some of the regions, we pick up a lot of mediastinal tumors, lot of mediastinal lesions. So incidental findings. And some of them they present with the symptomatic, compressive symptoms because of the mediastinal lesions. And we as a pulmonologist, we see a lot of mediastinal adenopathy. So any mediastinal adenopathy, there are 4 differential diagnoses: tuberculosis, sarcoidosis, and the primary malignancies like lymphomas and metastatic lesions. So apart from this, a lot of tumors, benign and malignant, and a lot of diseases in the mediastinum. So we have a wonderful highlighting points we are going to discuss. The number 1 highlight points we are going to discuss are: understand mediastinal anatomy exactly as it appears on EBUS ultrasound and bronchoscopy. Learn how vascular structures, airways, and station guide needle positioning and safe sampling in real time. From CT to EBUS, mental mapping made simple to translate axial CT images into the live EBUS view with the practical orientation tricks every operator actually uses. 4th is the identifying common anatomical traps and variations that lead to complications or false negative biopsies. Finally, see how procedural anatomy directly impacts diagnostic yield, needle choice, and decision making during EBUS. So we have a wonderful a speaker and panelist. May I introduce the panel? Today's speakers and panel start with may I introduce the Dr. Sanjeev Mohan, MD, DNB, DM, consultant pulmonologist, Kailas Healthcare, Noida, Uttar Pradesh. He did an MD from Grant Government Medical College, Mumbai, a DM from the Vardhaman Mahavir Medical College and Safarjung Hospital, New Delhi. And he has several publications, more than 20 publications in various national and international journals. Author for book chapter in a case-based learning in arterial blood gas analysis, and membership in Indian Chest Society, European Respiratory Society, Indian Sleep Disorder Association, Indian Association of Bronchology, Chest Council of India. Dr. Sanjit, the main area of interest are interventional pulmonology, ILD, lung cancer, and sleep disorders. Welcome, Dr. Sanjit Mohan. And we have, I introduced Dr. Mohan Venkatesh Pulle, consultant, thoracic surgeon, working in the Institute of Chest Surgery, Chest Onco Surgery, and transplant surgery in Medanta, the Medicity, Gurugram. He received so many achievements. He received the President's Gold Medal in Thoracic Surgery, Dr. B. Ramamurthy Gold Medal in General Surgery, Lawrence Young Scholar Award, Ravi K. Gerard Award, Dr. N. K. Mehra Award. He has more than 50 publications in various national and international journals. And the Mohan's area of interest are tracheobronchial surgery, video-assisted thoracoscopic surgery, lung transplantation, and lung tumors. Welcome, Dr. Mohan Venkatesh Pulle, for this wonderful webinar as a panelist from Thoracic Surgical Side.
Thank you, sir.
Welcome. May I introduce Dr. Ankit Bansal, Senior Consultant Pulmonologist and Critical Care from Fortis Hospital, Jaipur. He is a teacher, National Board Examination teacher, formerly ISCCM teacher, the Organizing Secretary of National Conference on Emergency Medicine, Core Committee member of National Conference Neurosurgery, and the State Head Chest Council of India, Rajasthan Chapter, Chairperson for the Jaipur Forum for Clean Air under the aegis for Doctors for Clean Air and Lung Care Foundation. So, Organizing Secretary, Annual Event Sepsis Symposium, Jaipur, Advanced Cardiac Life Support, instructor by the American Heart Association, and awarded an Inspiring Respiratory Specialist of India 2024 from Times Group and ET at Delhi. Part of more than 100 academic events, conferences, workshops, international, national, state level, and the field of pulmonology and critical care, as well as a faculty and organizer. So part of the reputed international national society in the field of pulmonology, critical care, and allied sciences as a life member. So welcome, Dr. Ankit Bansal. So may I introduce Dr. Thomas Vadakan. So Professor Thomas is a professor, Department of Pulmonary Medicine, Amala Institute of Medical Sciences, Thrissur, Kerala, God's own country. And he is a past president of Indian Medical Association, Amala Nagar branch, and the past president of APT, current General Council member of APCCM, Organization Chairman of PulmoCon 2020, APTCon 2020-2021, and Organizing Treasurer of NetCon 2023, member of a Central Division of TB Association of India. He has received the Best Chest Physician Award from Kuwait Ministry of Public Health in 2009, and the President's Best Appreciation Award from the Indian Medical Association President. So he has more than 25 publications in Index Reviewed Journal, and the editor of the textbook of lung oscillometry testing and interpretation, and the author of 5 chapters in various textbooks and publication. He is a reviewer of the Indian Journal of Tuberculosis and Pulmon. Welcome, Dr. Thomas Vadakan, sir. Last but not the least, may I introduce Dr. Priya S. Punyani, consultant thoracic and oncosurgeon, open and video-assisted thoracoscopic surgery, robotic surgery, working in an Asian Cancer Institute, Apollo Hospital, MGM Hospital, and Medical College in Mumbai. So, ma'am is a doctorate of a national board in thoracic surgery, fellowship in surgical oncology from the Kolkata, fellowship in advanced robotic and innovative surgery, fellowship in minimally access surgery, training in uniportal wards at Shanghai. So he has major achievements like more than 15 national and international publications, and is a reviewer of multiple peer-reviewed index journals, and member of Chest Council of India, ISO, ASI, IACTS, and ISTST. He has received several awards. The main award, award for the presenting work on bronchopulmonary carcinoids at the World Lung Cancer Conference in 2021. And he has presented various papers in the national level, international level, with a paper and poster presentation. welcome Dr. Priya Madam for this prestigious webinar. So the today event flow. Today the event flow will be, there are two back-to-back presentations. First, to start with mediastinum through EBUS, pulmonologist's eyes by Dr. Sanjit Mohan, followed by mediastinum through the surgeon's eyes by Dr. Mohan Venkatesh Pulle. Over to Dr. Sanjit for the presentation on mediastinum through EBUS. Over to Sanjit. Thank you.
Hi, good evening, everyone. I am Dr. Sanjit Mohan, consultant pulmonologist at Kailash Healthcare, Noida. I'll be talking about EBUS landmarks today. My talk will mostly consist of images rather than the statements, because we believe that words we tend to forget and images are imprinted in our brain. So let's start our presentation. So basics first. This is the IASCLC, the mediastinal node mapping. So this is a beautiful diagram showing all the mediastinal lymph nodes in the coronal section and the sagittal section. So this is station 1, for which we usually don't need to do an EBUS, because this can be easily sampled through the USG guided biopsies or the FNACs. What I want to make you clear is make an imaginary line from the left lateral wall of trachea, like here. So this imaginary line will divide your mediastinum into right and left side. Anything on the right side will be the right-sided lymph nodes. Anything on the left side of it will be the left-sided lymph nodes. Okay, so this is for station 2 and 4 specifically. So this is the sagittal image showing the station 3P and 3A. So going to the approach. So for the EBUS, EBUS can help us in diagnosing station 2, station 4, station 7, station 10, station 11, in some cases of station 3P. And if we combine our EBUS with the EUSB, that is inserting an EBUS scope into the esophagus, we can additionally screen for station 8, station 9, and sometimes station 5 and 6 as well. So, if we are doing a staging EBUS, it is mandatory that you do a EUSB also after you complete your EBUS. So color Doppler, this is a basic thing. So this is the advantage of linear EBUS, that we have a color Doppler in it as compared to the radial EBUS, where we don't have the color Doppler option. So in the linear EBUS, it is mandatory to do the color Doppler. Why? Because it helps us differentiate between the lymph node and the vessel. Also, it helps us to know the vascularity of the lymph node. So suppose if you are puncturing a vessel and you hit the, suppose if you are puncturing the lymph node and you hit the vessel, the efficacy of the procedure goes down. So you have to make sure you see the lymph node and see the vascularity in the lymph node, and you try to puncture where the vascularity is less, so to increase the yield of the procedure. So a safety pearl, if there is a doubt, Doppler it out. So the backbone of EBUS anatomy. So what is the backbone of EBUS anatomy is the vascular structures. So make this thing very clear into your mind that if we know the vessels, if we make mediastinal vessels our friends, you can identify the lymph nodes very without any doubt, and there will be never any doubt in mislabeling the lymph nodes. So if you can easily identify the vessels, lymph nodes can automatically be identified by you. So what are the most common vessels which needs to be identified in the mediastinum is the azygous vein, because it differentiates between the station 4R and 10R. The superior vena cava, it differentiates between 2R and 4R. The ascending aorta for station 4L, the pulmonary artery for station 10 and 11, the left atrium for station 7, and when you're doing EUSBs, descending aorta for station 8 and 9. So starting from the station 2, as I've told you, there is an imaginary line on the left lateral wall of trachea. So the upper border of the station 2R is formed by the manubrium sternum, and the lower border is formed by this is the left brachiocephalic vein entering into the superior vena cava. So the lower border of the left brachiocephalic vein entering into the superior vena cava forms the lower border of the station 2R. Okay. This is the axial CT image showing the same thing. This is the imaginary line. This is the left brachiocephalic vein. This is the right brachiocephalic artery. This is the left common carotid artery, and this is the left subclavian artery. So anything on the right side forms the 2R lymph node. Anything on the left side forms the 2L lymph node. This right brachiocephalic artery further divides into right common carotid and the right subclavian artery. Why I'm telling you this is because, see this. This is the endoscopic view of the EBUS. So when you pass the vocal cords, approximately after 3 to 4 tracheal rings, when you position your EBUS probe towards the 1 o'clock position, you see this structure. This is the lymph node. This is the right subclavian artery and the right common carotid artery. So this lymph node is the station 2R. The right subclavian and the right common carotid are the branches from the right brachiocephalic artery, which you are able to appreciate when you are screening for the station 2R. Going to station 2L, this is the axial CT scan showing the station 2L. This is marked with an arrow. This, I have told you, is the left brachiocephalic vein. This is the right brachiocephalic artery. This is the left common carotid artery, and this is the left subclavian artery. So what do you see? This is the node, and behind the node, what do you see? This is the left common carotid artery. So if we put our EBUS probe here, we are able to appreciate the lymph node, and below the lymph node, we are able to appreciate the left common carotid artery. So this is the image from the same patient. So going to station 4R. So 4R, so basically the lower border of the station 2R, that is the right brachiocephalic vein, forms the upper border of station 4R. Station 4R is the Hughes territory. The lower border of the station 4R is formed by the lower border of the azygous vein. This is the azygous vein, which enters into the SVC and drains into the SVC. Station 4R is further divided into three group of lymph nodes, like anterior group, anterolateral group, and the lateral group. This is the axial CT scan image of a patient showing the station 4R. This is the ascending aorta, this is the descending aorta, this is the superior vena cava, and this is the azygous vein draining into the superior vena cava. So going into the endoscopic view of station 4R, this is a diagrammatic representation of the same. This is the image showing carina. Your EBUS probe is just above the carina facing 12 o'clock position. What do you see? This is the ascending aorta. So when you are screening for the anterior group of lymph nodes at station 4R, you see the ascending aorta. This. So when you are screening for the anterior group of lymph node, this is the lymph node, and below the lymph node, you find the ascending aorta. Now you rotate your EBUS probe towards 1 to 2 o'clock position to screen for the anterior lateral aspect of the station 4R lymph nodes. So what do you see the vessel above? This is the superior vena cava. So this is the anterior lateral screening. This is the lymph node. This is the superior vena cava. And here you can see a structure. It is actually the azygous vein, which will further go and drain into the SVC. Now you again rotate your scope towards the 3 o'clock position, that is more lateral. What vascular structure do you see? So this is a azygous vein which drains into the superior vena cava. So this is the EBUS image for the same. So this is the azygous vein. This is the lymph node at the lateral screening of the station 4R. So going to station 4L. So the lower border of station 2L, that is the forms the upper border of station 4L. That is the imaginary line at the upper border of the arch of aorta, and the lower border of the station 4L is formed by the imaginary line at the upper border of the pulmonary artery. So what vascular structures will you find at the 4L location? Correct. So it will be the aorta and the pulmonary artery. So this is the axial CT image of station 4L showing pulmonary artery and the ascending aorta. So what actually you get, you screen for 4L lymph node, you get the lymph node, and you are able to screen for, you are able to see the pulmonary artery and the ascending aorta. So where do you have to position your probe? So this is the image at the level of carina. At the level of carina, you have to rotate your scope towards the 9 o'clock position, and you see this beautiful structure. This is a Mickey Mouse sign, where you find a lymph node, that is 4L lymph node. Below the 4L lymph node, at the distal end, you find a pulmonary artery, and at the proximal end, you find the ascending aorta. Right. Now going to station 7. So station 7 is the easiest node to identify and the easiest node to sample. So this is the coronal section of the patient showing station 7. So this is the right trachea, right main bronchus, left main bronchus, right main bronchus divided into right upper lobe bronchus. This is bronchus intermedius. This is left main bronchus going to divide into left upper lobe bronchus and the left lower lobe bronchus. So anything just below the carina is the upper boundary of the station 7 lymph node, and the lower border of the station 7 lymph node on the right side is formed by the lower border of bronchus intermedius, and on the left side it is formed by the superior border of the left lower lobe bronchus. And below the station 7 you are able to get the left atrium. So station 7 is basically above the left atrium. So this is the endoscopic view of station 7. Station 7 you can approach from the right side, right main bronchus, as well as from the left main bronchus. When you are approaching from the right main bronchus, you have to turn your EBUS probe towards the 9 o'clock position. When you're inserting your probe from the left main bronchus, you have to turn your EBUS probe towards the 3 o'clock position. So what do you see? This is the vascular structure over at the carina. So this is the EBUS probe just at the level of carina. What do you see? This is the right pulmonary artery and the ascending aorta and the arch of aorta. So when you are putting a scope from the right main bronchus, you see the right pulmonary artery and the ascending aorta. And if you go further distally, you will be able to see the left atrium. But when you put your scope from the left main bronchus and position it towards 9 o'clock, what do you see? You first see the main pulmonary artery. Then when you turn your scope towards the 9 o'clock position, you're able to screen for the station 7 lymph node, which looks like this on the EBUS image. Now going to station 10R. So this is the axial CT image of station 10R. This is at the level of carina, showing bulky 10R lymph node and 10L lymph node. This is the endoscopic view. How do you have to go ahead with the station 10R? So this what you have to do is you have to come to the carina, screen for station 4R, then at the lateral aspect, then go down. You will be able to see the azygous vein. And when you are able to see the azygous vein, just proceed your scope further distally into the right upper lobe bronchus. So what do you see? This is the scope entering into the right upper lobe bronchus just below the azygous vein. This is the right carina 1. This is the bronchus intermedius, and this is the right upper lobe bronchus. So at the entry of right upper lobe bronchus, you'll be able to see the azygous vein, a lymph node. Okay, and if you pull your scope upwards in the cranial at the cranial end from the azygous vein, what will you be able to see? You'll be able to appreciate the station 4R, right? So going to station 10L, this is the axial CT image of station showing station 10L. This is the endobronchial ultrasonography image of station 10L, and just below the station 10L, you have a pulmonary artery. So what you have to do is you have to insert your scope into the left main bronchus. This is the endoscopic view where you can see the EBUS scope entering into the left main bronchus. This is the left lower lobe opening, and this is the left upper lobe opening. So just when you start screening from the 4L lymph node, you see the 4L lymph node, you see the pulmonary artery, you keep pushing your scope distally until you see the pulmonary artery and a lymph node, and before entering into the left upper lobe bronchus. Just before the entrance to the left upper lobe bronchus, you'll be able to appreciate the lymph node and a pulmonary. This is the lymph node, and this is the pulmonary artery. So the lower boundary of the 10L lymph node is the opening of the left upper lobe bronchus. Now coming to station 11R. So station 11R is divided into 11R superior and inferior. This is a coronal image of the CT scan showing right main bronchus, left main bronchus. Right main bronchus is divided into right upper lobe. This is bronchus intermedius. This is right middle lobe and right lower lobe bronchus. So where to screen for station 11R superior? So this is the endoscopic image of right main bronchus. This is the opening of right upper lobe. This is the bronchus intermedius, and this is the right carina 1. So at the level of right carina 1, you are able to screen for the station 11R superior. So what you have to do is you screen for azygous vein, come down to the station 10R, then further come down, then further down you will see the right pulmonary artery. Then further down when you come, you will reach the right carina 1, where you will be able to appreciate the 11R lymph node, 11R superior lymph node, and below that you will be able to see the right pulmonary vein. Now further, if you push your scope distally, you'll enter into the right bronchus intermedius. Here you can see this is the opening of right middle lobe and this is the opening of right lower lobe. So further, when you come into the right bronchus intermediate, you rotate your scope towards the 12 o'clock. So between 12 o'clock to 1 o'clock, you are able to screen for the station 11R inferior. And this is the endoscopic image showing station 11R inferior. Now going to station 11L. So station level for station 11L, this is the endoscopic image of left main bronchus. This is the left carina 2. This is the left upper lobe opening and this is the left lower lobe opening. So just at the level of left carina 2, you will be able to screen for the station level L lymph node. So you cannot end my, I cannot end my talk just with the EBUS, because many a times we miss some nodes if you do only EBUS. So EBUS should always be complementary with the EUSB. You should always do USB, especially when you're doing a mediastinal staging. So EUSB will help you to further screen for station 8 and also for station 9. And many a times what happens, station 2L and station 4L can also be seen on the EUSB. And many times what happens, station 2L and station 4L specifically are very small. So when you're puncturing the station 4L from the trachea, because of the cartilaginous structure of the trachea, it is very difficult to puncture a small lymph node. So in those cases also, you can go ahead with EUSB, and because of the muscular structure of the esophagus, you'll be able to puncture the 4L lymph node very easily. And USB can also help in puncturing the station. You can also help in identifying the station 5 and 6. So the key takeaways from my talk is never sample without a Doppler. Doppler is must and mandatory before each and every puncture. Reconfirm anatomy before every pass. Withdraw and reorient if you are unclear with the anatomy, or if you miss, or if you forget actually where you are. Think procedural, not the textbook anatomy. Vessels are your compass. So you should learn by heart which vessels you will be, you'll have to learn by heart where exactly to screen for the vessels and which, because if you learn about the vessels, then you'll be able to easily locate the lymph node. Systemic approach improves accuracy and safety. So, so before ending my talk, I'll be ending it by a statement that EBUS anatomy is learned with your left hand more than your right hand. So you have to master your left hand first, so to avoid complications from your right hand. Thank you so much.
A very good evening, one and all. And first of all, I should congratulate the Chest Council of India for conducting such highly academic webinars, that too for many years and in continuation. And the present webinar is on the EBUS. So in the earlier presentation, Dr. Sanchit Mohan has very elusively presented the role of EBUS, the pulmonology eyes. So my next 12-15 minutes will be on the role of thoracic surgeon in the mediastinal staging, especially in the lung cancer. So the schema would be, after a brief introduction, we will discuss why mediastinal staging matters in lung cancer, and what are the staging modalities, and how a surgeon can actually help in these situations. So if we go by the Globocon data, the lung cancer is the fourth overall incidence in India, and it is also the fourth leading cause of mortality as far as a cancer-related mortality is concerned. And we have incidence of 19.3 million new cases and mortality of 9.9 million deaths in a year, which is a huge number as far as lung cancer is concerned. So whenever a diagnosis of lung cancer, we have an array of stepwise approach, starting from the clinical history to imaging, and then pathology, and then the diagnosis and staging. This is how a stepwise approach in lung cancer actually goes. At the end of all these, the patient will ask you, or we have to answer ourselves these three questions. What is the type of the cancer? What is the biomarker status? And what is the stage of the cancer, which is the most important thing we should be able to answer. Why staging matters? Because it is the most important predictor of survival, and it determines the appropriate treatment options and helps in the prognostication of the lung cancer. And as we can see here, you can see as the stage we progress from 1A to 4B, you can see the 5-year estimate. You can see from 82% 5-year estimate of survival, which drops to 7% as the stage actually increases. And the most important topic, which is pertinent today, is why mediastinal staging is very, very important, or mediastinal lymph node sampling is very, very important. Because the nodal status determines the stage, and nodal status determines the treatment options. And it also a very important component which affect the survival. Why I'm saying this? You can see here the 5-year relative survival in localized disease, which is confined to the primary site, it is 52%. As you can see, even the involvement of the regional lymph nodes, you can see there is a 50% drop in the survival. You can see the 5-year the survival curves here. In N0 disease, the 5-year estimate is of 76%, and in N1 52%, and N2 38, and N3 is 25%. You can see, how drastically, if the lymph node stations are involving from localized to the mediastinal to the opposite mediastinal, the survival is actually significantly is coming down. So we have significant many guidelines regarding when mediastinal staging is actually required in lung cancer by National Institute of Healthcare and Excellence, and then we have ACCP, ESMO guidelines, and then ERS, ESTS guidelines. So the one thing that is very clear is that the factors which say that mediastinal staging should be done in lung cancer is a nodal size of more than or 10 millimeter. That means more than a centimeter of lymph node, which is PET positive, which is evident in PET scan, and clinically they are positive. And the most important thing is a central tumor, which is size of more than or equal to 3 centimeters. And even it is non-FDG tumor, which actually happens in a few of the slowly progressing adenocarcinomas. So these are the criteria where we have to stage the mediastinal. And the next question comes, what are the investigative tools for the mediastinal staging? We have imaging techniques, endoscopic techniques, and the surgical techniques. So overall, although we aim for the best of the tests, the test which should be the highest sensitivity and highest negative predictive value is the most important or important test in mediastinal staging. However, a rate of 10% unforeseen N2 disease is acceptable in lung cancer staging. So first I will discuss about how a surgeon can assess the mediastinal staging. There are several modalities which we name as cervical mediastinoscopy, video mediastinoscopy, extended mediastinoscopy, VAM lung, TAM lung, and then VATS. See, there are various methods in which mediastinal lymph nodes can be sampled or mediastinal pathologies can be dealt with, which are in the armamentarium of the surgeon. So let's start with the mediastinoscope. Mediastinoscope is actually invented in late 1950s, where the futile thoracotomies many of the futile thoracotomies were happening for the lung cancer. As soon as they go inside, they find it very highly advanced. So to prevent those futile thoracotomies, so people have put a laryngoscope first into the mediastinum, and then sampled few of the lymph nodes. But it is not a conventional mediastinoscopy until when 1959 Carlens has actually started doing this mediastinoscopy by inventing this kind of instrument. This is how a mediastinoscope look like. It's a L-shaped. You have a barrel down with a curve, more like it's a rigid bronchoscopy that you people do, where we put this into the mediastinum in the pretracheal plane. And it is a fixed barrel, it doesn't open, it's a fixed diameter barrel. What you can maximum do with this is, and then you have several modifications by various people according to their needs. And it is like you are working in a small tunnel. Mediastinum is a very enclosed space surrounded by major vascular structures and the tracheobronchial structures. So actually these lymph nodes are embedded in those tight spaces. So what mediastinoscopy do is you have to work in a tunnel, that small, very narrow tunnel, by using a single hand. That is the major disadvantage of the mediastinoscopy. So this is the first hindrance was, you can see here, this is how a mediastinoscopy is done conventionally, cervical mediastinoscopy. The surgeon will actually will hold the instrument with one hand, and he has only one hand to work with. Actually, surgeons are not used to this kind of procedures. These surgeons trained to do the surgeries by both hands. But by doing this way, it actually becomes a non-bidextrous kind of situation, and it is a very, very small tunnel vision, narrow area, which is surrounded by bronchial structures, and no scope for errors in this mediastinoscopy. That is the reason training juniors is very, very difficult. And in those cases, in that situation, sampling is more important, is the only possible thing that other than complete removal or dissection of the lymph nodes. And then 30 years later, the LIRAT has actually connected a video to the mediastinoscope, which became video mediastinoscope, where the visualization is better, accuracy is better, you can teach the juniors better, and there is a standardization of the technique that was happening. In the earlier days, what only surgeon can see what is happening inside the mediastinum, but now everyone can see what is happening in the mediastinum, so that better teaching and the standardization of technique is possible. And then comes the another advancement, which is mediastinoscope with the separable blades. As I said, it's a very narrow space. If you can increase the space by separating the blades, so this is how this technology has come, where you can actually, this space can be increased in the diameter so that you have a more working space. So that's how this mediastinoscope with the separable blades has come into picture. So the various companies have started producing or inventing the new technologies in this mediastinoscope, where a scope actually can be put, a camera and a light source can be put within the scope, and the improved visualization and the lighting can be done. Well, it can be improved in this situation. So this is the latest advancement that we have got here, is the Linder-Dahan video mediastinoscope, and where this is the latest, the possible video mediastinoscope that we have. So, as I said, that is a mediastinoscope with separable blades. You can see this, the two blades are there which are retracting away from each other, so that the vascular structures can be lifted away from the trachea, so that you can visualize the mediastinal lymph nodes very well. And you can have a stand in which it can be fixed, so that the surgeon can actually work better with his both hands. And there is something called extended mediastinoscopy. It is between the brachiocephalic vein and the arch of aorta. You put the scope actually in the pretracheal plane. We go along the anterior wall of the trachea. But level 5 and level 6 lymph nodes, which are called para-aortic and subaortic lymph nodes, are difficult to sample, or it's not possible to sample by this kind of conventional mediastinoscopy, and where the extended mediastinoscopy has come into picture by putting the scope in between the brachiocephalic vein here and the aorta. So you can sample those level 5 and level 6. And then with this bidextrity, which is coming to the surgeon because of the separable blades, enhanced imaging, so people started doing the extended, the significant mediastinal lymph node dissection also, not only the sampling, but dissection also by doing this, which is called VAMLA, video-assisted mediastinal lymphadenectomies. You can see here the surgeon actually is creating a pretracheal plane. The aorta will, and the plane is between the trachea, exactly over the anterior wall of the trachea. All soft tissues and the aorta vascular structures are lifted off. You create a plane there, put a scope. You can see here, put a scope. First, you visualize the left paratracheal lymph nodes, dissect those lymph nodes, taking care not to injure the left recurrent laryngeal nerve, and then you come to the center compartment where you lift with the one blade of the mediastinoscope, lift the pulmonary artery, and you will see the subcarinal lymph nodes, which you can dissect very well by this technique. And then we'll come to the right paratracheal, which is the right compartment. We actually lift the vessels, and carefully we will take out the right 4R and the 2R lymph nodes ensuring not injuring any important vascular structures such as astragalus vein and the superior vena cava. I thought to put the surgical videos, but these diagrams explain much better than a surgical video where it is difficult to understand what is actually happening. And then comes the another important is called TEMLA, that is called transcervical mediastinal lymphadenectomy. So it is another advancement of VAMLA where it is complete extensive lymph node dissection can be done by the transthoracic route. It's actually like a transcervical thoracic surgery where the scope is what the mediastinal scope is used less. It's conventionally an open surgery. All stations except the inferior pulmonary lymph nodes can be done by this procedure. It will have a very big neck incision, which is about 4 to 5 centimeters. And then you can see here a stand, sternum lifting stand will be there, and a hook is there. It will be put behind the sternum. The sternum will be lifted up, and then surgeon does extensive lymph node dissection, starting from the highest mediastinal to the level 10 level lymph nodes. And usually it is done a few days before the surgery. And once the lymph node report comes, they can plan for the definitive surgery. So this is how the mediastinal lymph nodes accessibility by the staging technique. If we conventional cervical mediastinal you have upper and lower paratracheal right and left, and you can do the 10R in some cases, and then subcarinal lymph nodes level 7. By extended mediastinal as I said, we can sample the level 5 and level 6 also. And the VAMLA technique that we have discussed, we can go up to level 8 lymph nodes, level 7. And the unimportant thing is we can do complete dissection with VAMLA. TAMLA, it extensive, it includes more and more lymph nodes. It has the highest possible yield, starting from 2R, 4R, 2L, 4L, level 7, level 8, and level 5, level 6 by doing extended mediastinoscopy. And the VATS, which is another technology where we can actually go into the pleural cavity and sample a significant number of significant stations of lymph nodes, which are not accessible by the mediastinoscopy techniques. And then comes the EBUS techniques, which is already been described. I'm not going to repeat it. The surgical technique characteristics, if we see, the sensitivity and the negative predictive value is actually very good. Start from more than 75% to up to more than 95% of negative predictive value in the various mediastinoscopic techniques. So the second hindrance that came, so all things are going well, and then the EBUS has come into picture, which is actually started by surgeons in 2004, where and it actually has revolutionized the mediastinal lymph nodes sampling. So the main differences between these two are EBUS is definitely a less invasive. It can be done under conscious sedation, as recommended as initial step with all these advantages, and rapid onset examination is possible and with negligible complications. Whereas mediastinoscopy is a surgical procedure should be done in OT under general anesthesia. And of course, it is the gold standard. If EBUS is doubtful, then gold standard is mediastinoscopy. The false negative rates are very few, and the complications are slightly higher than EBUS, but it should be done by very experienced hands. So EBUS versus surgical methods, again, we see the EBUS is definitely fares better in the reduced time to treatment decision, because you do EBUS, do on-site evaluation, you can say if the lymph node positive or not. It is definitely cost effective. Invasiveness is less and the complications are better. Complications are lesser. And EBUS equals with the sensitivity and negative predictive value. As we discussed initially, the sensitivity and the negative predictive value is the most important thing for a technique that we are sampling the lymph nodes, very important. However, EBUS has two major limitations, that is the variations in the clinical practice and the operator experience. The question is, are EBUS results are reproducible? As I said, it's operator dependent. Single center experiences have false negative rates of almost 20%, which is a very high price to pay in lung cancer diseases. So that's why the ESES guidelines in the 2014 has said even the mediastinoscopy is negative. You have to the EBUS is negative. We have to plan for mediastinoscopy to prove them negative and then plan for the surgery. And then the question is when to do this mediastinoscopy or the surgical techniques. To my mind, there are three indications where you have to do surgical mediastinal staging. Number one, there is a patient with negative PET scan and negative EBUS. TBNA, but there is a high suspicion of mediastinal positivity, like in situations where there is high SUV max of the primary tumor. The primary tumor is highly avid and high SUV of the hilar lymph nodes, in which there are the hilar lymph node, the N1 disease is positive, but you have to prove N2 positive or not. But the EBUS came negative. So these are the situations where the EBUS TBNA the surgical mediastinoscopy is better than the EBUS TBNA. And in second scenario is a less experienced group who are doing EBUS, are the hospitals where EBUS is recently started, where the sensitivity and negative predictive value is actually less. In those situations, the surgical mediastinal can do better. And central tumors with nodes less than 5 centimeters. The central tumors, the positivity of the mediastinal lymph node is definitely high compared to a peripheral tumor. So in those diseases, and the other important thing is the size of the lymph node is very, very important, which determines the EBUS TBNA positivity. So what it means is if the size of the lymph node is less than 1 centimeter, the sensitivity of the EBUS to find out the malignancy is less. So the larger is the lymph node, the better is the EBUS yield. So in those situations where there is a central tumor and the lymph nodes are small, you are greatly suspicious of those lymph nodes, and those situations you can do a surgical mediastinal. Another important thing is the restaging technique, where you actually given a neoadjuvant therapy. In those situations, if you do a EBUS, the yield of the sensitivity of the EBUS in those situations post neoadjuvant therapy is less. So in those situations, the surgical mediastinal is phased better. So but sometimes, in the best of the situations, all the techniques, the recommendations that we are talking about, may not be, possible in all the scenarios. As I said, EBUS in Denmark, in one study, the EBUS as initial staging is done in only 43%. Mediastinal is only 10%. And strict invasive mediastinal staging is only 19% in countries where there is a strict, adherence to the things. India, we are actually very far from the reality. So the balancing act, what we should do here is, if there is a node which should be coming positive, the possibility of a node coming positive, you choose for EBUS. If there is a node, the possibility of node coming negative, we should go for mediastinoscopy. So this is how we can balance the act here. To conclude, accurate mediastinal staging is the backbone of the lung cancer management. EBUS and US is the first line of management, first line of sampling all these lymph nodes, which has very good success rates, very good sensitivity. However, the mediastinoscopy remains the gold standard for the tissue diagnosis, and it is indispensable when EBUS or US is negative, but the suspicion of the mediastinal nodes positivity remains, and there are small mediastinal lymph nodes where EBUS sensitivity decreases, and in cases of restaging after neoadjuvant therapy, where the sensitivity of the EBUS actually comes down. So mediastinoscopy is no longer routine, not done by people very regularly, but it remains the ultimate arbiter of mediastinal staging when you want the certainty, which is important and the most important in the lung cancer management. Thank you so much.
Welcome back. Thank you, Dr. Sanjit Mohan and Dr. Mohan Venkateshpulli, for the wonderful presentation. Dr. Sanjit, you presented mediastinum through EBUS, pulmonologist's eyes. So you put anatomical lymph nodal stations with endobronchial ultrasound view and CT sagittal images view wonderfully. So it's all the nodal stations. So beautifully you explained in detail about that. So thank you very much. And Dr. Mohan Venkateshpulli, very nice presentation on the mediastinum through the surgeon's eye using the mediastinoscopy. Yes, mediastinoscopy is a gold standard. So diagnostic tool to diagnose all kinds of mediastinal lesions wherever. But EBUS, we can't reach all the stations, all the areas in the mediastinum. So for the past 2 decades, a lot of advancements happening in the optics, the fiber optics and the endoscopic instrument, and the high-tech anesthesia, monitored anesthesia care, using the intravenous sedation, using the peritoneal propofol, etc. So EBUS is equally matching to the mediastinoscopy, but still mediastinoscopy is a gold standard. There is no doubt at all. So we can reach all the places. EBUS 80 to 90% as an interventional pulmonologist, we reach the mediastinum, whichever the stations, so we can reach. Certain for 10 to 20%, we may not reach the mediastinal nodes, etc., like para-aortic, subaortic, 5, 7, and all. So that kind of thing, definitely the surgeon's help is very important, thoracic surgeon. So thoracic surgery and interventional pulmonology are a complement to each other, like EBUS, USB, and the mediastinoscopy, all complement to each other. We have to choose the patient meticulously after thorough examination. We have to have the multidisciplinary discussions with the radiologists, thoracic surgeons, and the pulmonologist, then we have decided so which tool to reach the mediastinum. So we had a wonderful presentation by two talks. So pulmonologist medical perspective and the surgical, both are interventions, fantastic presentations. And there are some advantages, disadvantages, and minor complications and all. So previously, for any mediastinal lesions or the lung lesions, we rely mostly, nowadays, now also we rely most on the CT-guided needle biopsy. There are a lot of complications using the CT-guided needle biopsy. If the centers don't have the facility of mediastinoscopy or endobronchial ultrasound or with a good interventional gastroenterology department, they use the USB and all. So a lot of complications if you submit the patient for CT-guided biopsies, bleeding, pneumothorax, etc. But EBUS, there is a very, very, very negligible amount of complications with the modern anesthetic techniques and the scopy with the magnifications. We can do the wonderful tissue diagnosis. So tissue is the issue in a case of everywhere. So the lung cancer diagnosis and the staging purposes, so very, very important. The interventional procedures like EBUS or mediastinoscopy. So a lot of advancement happening in all the fields. So with that, so I thank you for the two presenters, Sanjit and Dr. Mohan Pillai, for the wonderful presentation. So we'll move on to I request all the delegates, so please post your questions pertaining to this topic like mediastinal anatomy for the EBUS operator. We'll take the questions appropriately. We'll start the questions first with Dr. Ankit. So Dr. Sanjit presented about the CT images of lymph nodal stations and the endoscopic EBUS view and all. So Ankit, may I ask one question? CT is an axial plane, but EBUS is a sagittal plane. So what is your personal mental framework to translate CT images into the real-time EBUS orientation? Ankit.
Thank you, sir. Thank you, CCI, for giving the opportunity to speaking on this respectable forum. So, if we see, either we see CT scan or we see EBUS, the anatomy is relatively same. But what we are working, there are different planes. So in CT, we have an axial plane, which is static and which is an external view. Whereas in EBUS, it is a sagittal and an oblique, but it is a dynamic view and it is endoluminal. That is important. So, as rightly said by my dear friend Dr. Sanchit, that vessels are the compass and your lymph nodes are your destination. So you should never navigate without your compass. So while you are moving sagittal, it is important to demarcate your landmarks of vessels. You should identify the vessels, either it could be pulmonary artery, aorta, SVC, or azygous vein. By locating those vessels, some way or the other, you can plan or you can make a mental makeup to sample your lymph nodes. So it is very important because as we know that CT scan move from slide to slide in slices and EBUS moves craniocaudally. So that has to be correlated accordingly.
Thank you. Fantastic answer by Ankit. So we have to coordinate both images and appropriately hit the targeted areas by the EBUS needle and all. Thank you. Move on to Dr. Thomas Vadakan, sir. So the role of interventions like EBUS or mediastinoscopy in lung cancer diagnosis and staging is very, very important. So Thomas, sir, what are all the limitations or future directions for EBUS TBNA in lung cancer care? Thomas.
Thank you, CCI, for the opportunity. The main limitation of EBUS guided biopsy is the limited tissue. Because nowadays we need more tissue for biomarkers, IHC, and NGS. This is often requested from the oncology colleagues, so that's a must. Many times they need more tissue for the completion of the workup. Second thing is false negative. The FDG uptake may be positive, but our EBUS may be negative. So many factors, maybe necrotic node, maybe fibrotic node, maybe calcific node. So all those things will contribute to, even the operator technique is also important. The experience of the operator is the most important. And some nodes I think already discussed, like para-aortic, sub-aortic, not accessible with our conventional EBUS. But EBUS is also evolving in such a way that these limitations can be addressed, like smarter imaging, especially thinner convex probe, where you can advance the scope little beyond than the conventional EBUS scope. And we can have elastography, where you can identify benign and malignant nodes. And also you can choose the right area for biopsy by using elastography. And you know, EBUS, though it is a diagnostic tool, now it's coming in the platform of theranostic bronchoscopy procedures, because many case reports are coming up in the treatment modality, like introduction of the drug into the node and placing for the radiotherapy, etc., etc. So I think EBUS is evolving. Many future directions are there to improve its limitations. That's all from my side, Dr. Jayaraman, sir.
Thank you, Thomas, sir. So EBUS is evolving. So there are some limitations. So nodal station 5, 6, as of now we can't enter, but in future, definitely, there is a chance to take the nodal lesion biopsy from the nodal station 5 and 6, and a lot of therapeutic indications also in future. So thank you, Thomas, sir. Move on to Dr. Sanjeev. Can you sample station 5 and 6 through EBUS? If yes, how? There is a para-aortic and sub-aortic nodes. How to take the lesion? Just now, Thomas told you update.
Thank you so much, sir, for the question. I'm glad that you asked this question because I had missed this in my presentation. So if we talk about station 5 and station 6, like the para-aortic, so basically, if we talk about the anatomy, station 6 is like lateral to the arch of aorta, and whereas station 5 is lateral to the ligamentum arteriosum. So these lymph nodes are not actually in direct approximation with either the trachea or the esophagus. There is always a vascular structure between them. So it is difficult to sample them. So this is not obviously for the beginners, but there is a technique called transvascular needle aspiration. So there are some papers who have shown that we can sample the station 5 and station 6 through the trans-aortic approach. So in those, if we have a station 5 or 6, we can go ahead with the transvascular needle aspiration. To go with that, it will be slightly difficult attempting these nodes from the trachea because of the cartilaginous structure of the trachea. So better would be to go into the esophagus. And since the esophagus has a muscular structure, it will easily gives the way for the needle, and we can go directly into the level 5 or level 6 nodes. But the thing is, whenever you are doing a transvascular needle aspiration, you should always do a ROSE, rapid onset evaluation, when you're doing it. Yes.
Fantastic answer for the approaching the 5 and 6. That is the para-aortic and sub-aortic nodes through the EBUS. Yes, we can take through the transvascular needle aspiration. Or through the EVS, through the esophagus, we can take the approach the 5 and 6 lymph nodes. Thank you. Move on to the surgeons, Dr. Mohan sir. Are there any indications for mediastinoscopy as per current guidelines? The latest, the European Society of Medical Oncology suggests no need to do even if EBUS negative. So what are the true indications of mediastinoscopy in that lung cancer?
Thank you, sir. So this actually we have already discussed in my presentation, but I will explain it again. So I will see the mediastinoscopy in 3 time periods, we could say. So before the invention of EBUS, every patient, wherever if you want to do a mediastinal staging, mediastinoscopy is the only way you can sample the lymph nodes. And then EBUS has come. And then with the increasing experience of the people, more and more better acquiring techniques, introduction of cryo and all those things actually increase the yield of the mediastinal lymph nodes, and the sensitivity and the negative predictive value of the EBUS has significantly increased. It has reached almost the level of the mediastinoscopy. So probably we are in that second period, where if mediastinoscopy is only required when EBUS is negative and we are actually suspecting the positivity of the disease in the mediastin. But the next few years, after maybe few years, it will be like EBUS is the only way. I mean, there is no need to do, even if the EBUS comes to negative, then you can comfortably get away with confirmatory. You can take it as confirmatory without the need to do mediastinoscopy and prove it negative, because the techniques of the mediastinoscopy, the EBUS are so good, so that negative predictive value and the sensitivity is very high. However, to my mind, there are three situations I can foresee. Number one is there are central tumor. There is a big 3 centimeter central hilar tumor, and there is a lymph node in the mediastinum. Clinically, it is suspicious. EBUS you have done, which comes negative. But however, to the surgeon side, because that makes a difference between subjecting the patient for straightforward surgery, or you give the neoadjuvant therapy and then do the surgery. So this is one tricky situation where mediastinoscopy can actually prove that such kind of lymph nodes when there is clinical suspicion. And the second important thing is if there is a lymph node station which is not accessible by the EBUS or the US. So usually most of the lymph nodes are possible except for maybe level 5, level 6 lymph nodes, which is not accessible by conventional EBUS or US. And in some cases of probably level 9 lymph nodes, the inferior pulmonary ligament lymph nodes, if or 3A, the pretracheal, prevascular kind of lymph nodes. So if these are lymph nodes are suspicious or positive in the PET, and they are not able to actually sample those station lymph nodes, then it comes to the surgeon's array, where he can sample these lymph nodes. The level 5, 6 if you ask me, I would do by video assisted thoracoscopic surgery rather than doing extended mediastinoscopy. Whereas level 3 also I'm more comfortable in doing by video assisted thoracoscopic surgery. So level 9 also it's by video assisted thoracoscopic surgery. So these are the surgical techniques where when it is not possible by US or EBUS to do the sample the lymph nodes. And the third important thing is there is a hilar tumor, good sized, highly avid tumor, and the size of the lymph nodes is smaller. It is a avid lymph node, but the size of the lymph node is smaller. In those situations, because the size of the lymph nodes is actually proportional to the yield of the lymph node in EBUS. So the smaller is the size, the possibility of not getting the tumor, not getting an adequate sample is less. So that is one. The sensitivity actually comes down if the size of the lymph node is less. So that is a situation where I would go for mediastinoscopy. And the fourth important thing is if my pulmonology colleague is a fresh pass out and he is doing this EBUS in his initial stage, because the false negative rates in that situations are there. Technically he may not be able to sample it well, because the false negative rates are up to 15 to 20%. It's a very high price the patient actually pays if it falsely comes as negative and you do a procedure which is actually not should be done. So these are the 3-4 situations. And the last important is the restaging, because many now these people are getting neoadjuvant therapy in terms of immunotherapy or chemotherapy, and then they are getting actually the surgery done. In those situations, if you are restaging the mediastinum after neoadjuvant therapy, so it is always better to do by surgical technique than EBUS, because the sensitivity of EBUS in those situations is not more than 50 to 55%. So these are the 4 or 5 scenarios where actually, to my mind, where the surgery actually fails better than EBUS.
Thank you, Mohan sir. That's why mediastinoscopy is called it as the gold standard procedure.
Absolutely, because you can sample a large chunk of lymph node. The possibility of the sample is high. The possibilities of picking the tumor is high.
Thank you very much, sir. Over to Dr. Priya ma'am. What is your expert opinion about this discussion so far for the lung cancer staging and diagnosis using EBUS, US, or mediastinoscopy?
Yeah.
Welcome.
Thank you. Thank you. First of all, thank you, sir, for the warm introduction which you had given. I'm no ways an expert on this topic, but it was an excellent presentation by both the speakers, sir, and I thank you and CCI for this opportunity. I have excellent pulmonology colleagues where I work. So I almost never have to resort to surgical techniques to confirm my diagnosis. There are a few additions actually. There are a randomized control trial which already has come in 2023. which has proven that it was a non-inferiority trial, which has proven that even if patient has got a negative EBUS, we do not have to do a mediastinoscopy. So it already has come as a randomized control trial. So we are already the ESTS guidelines probably need to have a relook. That is what is the trending thing, because if RCT has proven that is the best kind of trial. RCT already has proven as early as 2023 that it is equal with a p-value of less than 0.025, and that also then had a presentation in ASCO in oncology rounds, review to the original article, saying that EBUS plus EUS, not only EBUS but a EBUS plus EUS has high sensitivity and specificity, and that combination is actually told to be equal to a mediastinoscopy. Second thing is when it comes to restaging after induction therapy. So, though I do agree that the diagnosis rates are quite difficult to achieve after with EBUS, but then the complication rates also after mediastinoscopy, with mediastinoscopy after chemotherapy, immunotherapy are quite high. That is a field which has undergone fibrosis. That is a field which has undergone lot of inflammation with chemotherapy, immunotherapy. So to do mediastinoscopy in that field also is very difficult. So articles and literature has quoted a yield of 77 to almost 90% with EBUS plus EUS. So I think the what I use and what our pulmonology colleagues, my colleagues use is, we never try to depend only on EBUS. We always have a EBUS plus EUS. That combination takes care of most of the lymph nodes. Yeah, the only trick which remains is level 5 and level 6. What Dr. Mohan has said. That is one place where EUS, if we are able to get through esophagus, transaortic is good. Otherwise, that is one place where either someone who can do VAMLA or else where video assisted thoracoscopy surgery is useful. So, if suppose someone has a right-sided 4 by 4 centimeter tumor with a single level 6 lymph node station on the opposite side, and that is avid. Now we are normally all of us will be stuck because that is actually opposite side mediastinal lymph node single station. Should I consider it N3 or should I consider it as not? And if he has history of tuberculosis in the past, I actually had that patient, a similar kind of patient. So then a mediastinoscopy in form of VAMLA or a EUS, a good EUS by a good person, that will be a very significant role to play, sir. So these are my two bits. But EBUS plus EUS, I think, is going to replace surgeons in this, and I have no problems about it. As long as you can give me to operate other cases, we are teammates. I don't need to do that.
Thank you. Thank you very much, Priyama, for the wonderful expert opinion about this comment. So EBUS and EUSB, so completely replace, you're telling as per your point, mediastinoscopy.
Will replace, already one RCT has come, so I think in the next few years, the guidelines also will get replaced. RCT has taken already, so that should slowly it will spread over.
Thank you, Priya ma'am, for your wonderful input on this diagnostic tool and therapeutic tool. I'll ask a question to Dr. Ankit. So regarding the CT images, which single CT slice do you rely on most before starting on EBUS case and why?
As we know that CT is a very important tool before we start an EBUS, so we should have a complete look at the CT before starting an EBUS. In that particular thing, one particular slide in which we have a carinal level, which we see in the CT scan, is very important, predicting both the anatomy, staging, and if we see the safety converge. So why it is important? Because at that particular level of station 7, we will expect carina where the trachea divided into two right and main left bronchus. So we can see both the orientation of both the bronchus there. We can see the pulmonary artery bifurcations. So basically we could see that how far it is from the airway. We will see the esophagus. So this is all important because the orientation will set up. So we will have an airway landmark, which will predict the carina shape and size, right and left main bronchus orientation. We have a less vascular landmark. We will see the pulmonary artery bifurcations. We will see the relative position of aorta or the superior vena cava. Soft tissue landmarks will also be there. So this will completely set up the things for us by which when we do EBUS, it will guide us not only to the carina, but also the subsequent node. Either it could be higher up or lower up, which we need to be sampled.
Thank you, Dr. Angil. Move on to Dr. Thomas, sir. How does EBUS TBNA support modern lung cancer management beyond staging? Thomas, sir? Thomas, unmute yourself. Thomas, sir, you are muted. Just unmute your mic. Yeah.
Yes, thank you. Thank you. Actually, the discussion is going well. These points already discussed, I think, because the most common indication for the EBUS in lung cancer is staging. But remember that those diagnosed case on treatment, they may improve with treatment. We want to know the remaining nodes are really part of malignancy or the healed, scarred lymph node or not. And quite often, when there is a progression, the question is whether the targeted therapy is resistant in case of advanced malignancy, or it's a new the worsening of the previous thing, like progression or recurrence of disease. So this is an important scenario where we need a repeat sample to evaluate, identify the histology, and do the biomarkers and the genetics behind, and to revise the treatment accordingly. Third aim of EBUS in lung cancer beyond staging is for therapeutic purpose, like intranodal drug therapy or intranodal placement of fiducial for planning radiotherapy to plan for radiotherapy, because this procedure is safer than CT guided placement. So I think these are few indications beyond staging for EBUS scoping.
Thank you. Thank you very much, sir. Move on to Dr. Sanjit. Already you presented this kind of discussions in your presentation. So which station you will not be able to sample through EBUS or USB?
Okay, sir. Thank you, sir. So if we combine EBUS and USB, I think we can sample most of the lymph nodes. The only lymph nodes which comes to my mind which will not be able to sample through the combined procedure will be 3A. So if there is a 3A lymph node, I'll definitely refer the patient to Mohan Venkatesh sir for the rescue.
Yeah, always.
Okay, fine. Yeah, again, over to Dr. Mohan, sir. Is it possible to access para-aortic nodes by routine mediastinoscopy? How to access level 5 and 6? Already you presented in your presentation. Just for the late joiners, you just once again you explain about that.
So the conventional mediastinoscopy cannot sample the level 5, level 6 lymph nodes. Basically, the conventional mediastinoscopy is done in the pretracheal plane. So whatever the lymph nodes in and around the trachea only can be sampled by conventional mediastinoscopy. So to sample the level 5, level 6 lymph nodes, which are para-aortic and subaortic, you have the plane of the dissection, the plane of the lymph nodes are something different compared to the normal conventional scopy, in which we have to put the scope in between the brachiocephalic vein and the aorta, and you can sample those lymph nodes. But if you ask me personally, if you do the external mediastinoscopy and sample these lymph nodes, I won't do. I will do by VATS very comfortably because you can have a better control over the lymph nodes, better dissection capabilities, and the possibility of iatrogenic injuries to the structures in and around level 5, level 6 lymph nodes can be managed very, very well. So the main important structures, injuries that we have to avoid is the left recurrent laryngeal nerve is the one nerve which actually starts at that region, which has to be saved while sampling these level 5, 6. And of course, the aorta, which is the main vessel, which has to be taken care of. So if you ask me, if you do extremediastinoscopy, no, I won't be doing it. I will do it comfortably, very comfortably by video-assisted thoracoscopic surgery.
Okay, thank you. Thank you very much, sir. Over to Priya ma'am. Your take on the any take-home points from this?
Yes, so I second with Dr. Mohan, sir. I second with Mohan. I myself also am very comfortable with video assisted thoracoscopic surgery, and I think that patients like 5 and 6, I am much more in control. I think surgeons overall, especially in the beginning, Dr. Sanchit had said a very important thing, even Mohan, that mediastinum is a very narrow window. So even training for juniors, nowadays the number of people who are doing it, it's a very narrow window. It's never a great thing. Whereas VATS, video assisted thoracoscopic surgery, is what we are trained in and out. So we have very good control over the procedure of VATS. So when it is VATS, therein we have more control, more expertise, and our dissection as well as our yield with control is excellent. So I think in EBUS plus EUS is the way to go, and if ever need arises, I think mediastinoscopy is in video thoracoscopic surgery is the next alternative.
Thank you, Priya ma'am. So our chairman, Dr. Krishnaji, is put up the messages. So far, we have nearly 1,800 logins in our panel. This CCI webinar on mediastinal anatomy for the EBUS operator. So thank you all the delegates. If you have any queries, please post in the chat box. Okay, so we'll move on to the discussion. May I ask queries to Dr. Ankit? Ankit, among the 4R, L, 10 and 11 stations, which station should be mastered first and what makes it technically forgiving? Over to Ankit.
Sir, if we see all the stations, that is the most commonly we mastered, I think the station 7, the subcarinal lymph node, may be a foundation station that we should say. Why it is so? It is a central anatomical anchor. It is a junction of both the lungs. Midline reference would be good. Upward you can go with 4R, 4L. Downwards you can go with 10, 11. Now it shows the best CT EBUS correlation because it is easily recognized. Pulmonary arterial bifurcation can be consistent with that, and anatomical variability is minimal in this particular station. So we can in a good way we can correlate the axial and sagittal mental conversion that we are talking about. Now, important thing is that relatively high diagnostic yield, because mostly frequently involved in lung cancer, and it's large, accessible, and so that there is an operator confidence in also that particular case. So for the beginners, definitely station 7 is the one which should be mastered first.
Thank you, Ankit. So pre-EBUS era, that is, we used to do conventional TBNA using the flexible bronchoscopy, video bronchoscopy. The subcarinal, that is 7 nodes, are very easy to take the thing without any EBUS at all. I'm talking about 2 decades before. And the 4R, that is right lower particle node also, if it is a big one, we can easily take the conventional. Yes. So nowadays, almost we have reached the all the other areas like 10, 11 and all with the EBUS guided. But for the beginners, subcarinal and right lower paratracheal is ideal way to start with. Thank you, Ankit. Move on to Dr. Thomas. So how to predict EBUS complications like bleeding or any other complications while EBUS procedures? Yeah.
Yeah, thank you, Jayaraman sir. May I ask you one question to you?
Please.
The most common cause of increasing heart rate of both patient and the operator?
Because of the tension among the operator. What is that?
It will be the bleeding in the airway.
So must, yeah.
So I think bleeding is one of the most complications which we come across, but with the training we can substantially reduce it. The 4 important points I want to discuss here is know the patient is the first thing. So we'll be routinely doing the coagulation workup and all. And in some case, in real emergency, we may have to proceed with the EBUS, though they are on double antiplatelet. In that case, we can arrange 2-3 platelet transfusion prior to our procedure. And know the node, that is the second most important step. because we should do the Doppler. We should review the images, post-contrast images, so we'll get a rough idea the vascularity of the node. And the Doppler will give you an idea about any intranodal vessels, also the vascular proximity to the node, and you can plan accordingly. Next important thing is know your needle. If the needle is big enough and the highly vascular structure, and if you use the suction in a vascular node, you are getting only blood, nothing else. So this is most important, and be prepared to tackle the bleeding, like any cold saline or whatever, balloon tamponade, whatever available in your armamentarium. So I think these are the 4 steps. Bleeding is the most common complications you come across with EBUS, and other complications are really rare, like needle breaking of the needle, and or when you repeatedly use needle, which happens in most of the EBUS centers in our country. I think I have answered your question.
Yeah, correct, fantastic. Yeah, bleeding is the one of the important complications we have to tackle effectively. So, over to Dr. Sanjit. How should one screen for lymph nodes? Is there any path to follow, like which node first and which second and all?
Thank you, sir. So basically, sir, if we talk about a diagnostic EBUS, so if a patient comes with a CT scan and suppose the CT scan shows only the station 7 lymph node, so what we have to do is we have to screen all the nodes. We just don't rely on the CT scan, because many a times CT scan may not show a node, but it can be, the node may be present on the EBUS when you do a ultrasonography EBUS. So how do I do is I start from station 2R, sir. Then from station 2R, we go to azygos, then station 4R, then below the azygos, station 10R, then 11R superior, then 11R inferior, then come to the station 7 from the right side, then screen the station 7 from the left side, then go to 11L, come up to the 10L, then 4L, then station 5, 6, and station 2L. So in this way, we follow this path. So it can be the opposite path also. You can start from the 2L and end at 2R. So if we follow this path, there are very less chances that you will miss any station. So this is for the diagnostic EBUS. And if we are doing for a staging EBUS, obviously we have to start from the N3 node first, then to the N1 node.
Okay, right. So this kind of path based on the diagnostic or the therapeutic or staging purposes, you can take the thing. Thank you, Sanjit. Over to Dr. Mohan, sir. So this discussion already you presented in our presentation. Some of the latecomers I'm asking once again, in brief, not in the procedure-wise, a difference between the mediastinoscopy and EBUS. Any specific advantage do you feel of mediastinoscopy over EBUS in today's world? Mohan, sir.
There are 3 or 4 points where EBUS fares better, definitely, compared to the mediastinoscopy. Number 1, the TOT, the turnaround time, that actually from the time you diagnose a patient with lung cancer and to actually start the therapy, especially the surgery. If you do EBUS and sample the mediastinal lymph nodes, prove them negative or positive, whatever it is, the treatment rate, the time to treatment is actually definitely better with EBUS compared to the mediastinoscopy. That's number 1. Number 2, it's definitely less costly compared to mediastinoscopy. For mediastinoscopy, you have to take to the patient to the OT. The patient should be posted in the OT. General anesthesia, 1 hour procedure, 1.5 hour procedure, and it requires a special admission and all those things. So EBUS can be done under daycare basis. It can be under conscious sedation. Experienced people are doing with under conscious sedation. Their yields are better. Now people are putting even cryoprobes into the mediastinum, and they are taking the samples from the mediastinal lymph nodes. So the first one, it is less invasive. Second is the time to the treatment is very less, and it is can be done under conscious sedation as a daycare procedure. And another important thing is that with all these advantages, it has a similar negative predictive value and the sensitivity compared to the mediastinoscopy. So these are the places where it actually fares better.
Yeah, thank you very much, sir, for the difference between mediastinoscopy and EBUS. So clearly, you may have mentioned the 5 points. Yeah, thank you.
Other thing I want to say to conclude. So I'm training the juniors. training the juniors, because if you compare mediastinoscopy as a technical, if as a taking a surgery, the possibility of the margin of error is very, very less in mediastinoscopy. Very, very less, because the lymph nodes are surrounded with the main pulmonary artery, SVC, aorta to one side, brachiocephalic artery. So the bleeding, if it happens, which I have seen from my own eyes, so you can injure all possible vessels that have been described before, starting from SVC, ajagus vein. We have injured ourselves. Whatever the vessel you mentioned there, everything we have injured. So we know how technically challenging this procedure is, and training the juniors is better with the EBUS compared to mediastinoscopy. That's why this mediastinoscopy is becoming a more and more a lost art, probably. Lost art, probably. Very few people know exactly how to do a mediastinoscopy properly.
Thank you, Dr. Mohan, sir. Now the question to Dr. Priya ma'am. Role of video-assisted thoracoscopic surgery in mediastinal diseases. Already you brief about that. There is a more control during the VATS procedures. If we use the VATS procedure when compared to the EBUS or the mediastinoscopy, we can reach all the areas using the VATS procedures. So what is your take on this, ma'am? Role of VATS in mediastinal diseases?
Mediastinal diseases, you mean to say, sir, nodes or sir, other diseases?
Mediastinal, whichever the disease, mediastinal nodes as well as the mediastinal tumors, both the diagnostic and therapeutic indication of VATS in the mediastinal diseases.
Yes, sir. Basically, mediastinal tumors, mediastinal nodes. Now, VATS is the VATS as well as robotic, wherever people can afford or do, is the way forward, because previously sternotomy used to be used for anterior mediastinal tumors, and the second best used to be the thoracotomy. But now with the VATS, the magnification, the control is also equally good. So, for example, in mediastinal germ cell tumor or thymoma, previously we used to use lot of sternotomies. I myself have done sternotomies on these in the initial part of my career. But now with the VATS also and robotic also, we get good magnification, good vision, and good control. So we are able to do the same surgery for even major tumors, big size tumors, with VATS, with a very small size incisions, and we are able to do the surgery comfortably with VATS with good amount of control. Come to even surgeries like lung cancer. Suppose if a patient has got borderline N2, wherein I am not so sure, and if the patient is not affording, say, for a EBUS or a mediastinoscopy, or if he is, I'm not very sure he will be N2. So if I do a VATS, a diagnostic VATS with a frozen section, it is a cost-effective procedure in a smaller hospital. On table, if the frozen section says that he is not N2, I will target the subcarinal lymph node. If he says it is not N2, then directly in the same setting, I can do a convert into proper VATS, do a lobectomy with the systematic lymph node dissection, and the patient undergoes the surgery also in the same setting, saving a lot of cost for the patient. So in certain scenarios, I can save money. At the same time, if I come to know the patient has got an N2 or an N3, I put a chemo port for the patient in the same sitting, and the patient can start chemotherapy in the same sitting. So VATS has made things easier for a lot of surgeons in bigger diseases, bigger bulk tumors, wherein we used to require very big incisions because we could not see things. Or we could not get control. Now we are able to do that. So faster return to work, lesser pain, less morbidity, less expense because lesser number of days in the hospital. And for smaller things like lymph nodes, where we are not able to go by routine stuff, we use our brains and work around. So things like borderline N2 and all that, if we use this kind of way, we are able to actually save patients money as well as their stress, because they're already burdened again under the burden of cancer disease. So we are able to save a lot of burden by doing things like this, 2 in 1.
Thank you, Priya, for the wonderful answers for this role of VATS in the mediastinal diseases, both diagnostic and therapeutic. Fantastic. So over to Dr. Ankit. Role of Doppler. Should color Doppler be mandatory before every puncture or only in doubtful cases? What is your take on this?
Sir, as we know that when the needle travels into a tissue, it is not directly visualized. So the most single dangerous error in EBUS, what we can expect, it is an unrecognized vascular puncture. So color Doppler is the real-time tool which is there, which reduces the risk. Sometimes the visual anatomy itself could be deceptive. Like the pulmonary artery maybe appear like an hypoechoic shadow resembling a lymph node. The flattened vessels may again mimic a lymph node. Sometimes the small veins may not be visible on the B mode. So in that particular case, I think the color Doppler should be mandatory before sampling each lymph node. For beginners, definitively yes. But as we gain experience from time to time, some people are more comfortable using without Doppler. But for a true study, Doppler should be used before each and every puncture.
Okay, fantastic. So Doppler is a very essential tool. So always utilize that to avoid unnecessary injuring our vessels. Thank you. Over to Dr. Thomas, sir. What are the extranodal indications and applications of endobronchial ultrasound bronchoscopy?
Yes, so far in the discussion, we are telling about the vascular structures are roadmaps to our destination, that is lymph node. Why don't you study the roads like SVC? There may be a tumor thrombi in the SVC or maybe a real thrombus in the SVC, which you can definitely you can visualize by using the probe with your EBUS scope. And that's an indication for stenting prior to radiotherapy or whatever. It will be helpful for your oncology colleagues. Also, aorta, we can just look at the aorta. What is happening? Is there any aneurysmal swelling? Is there any clot inside? Which can be really appreciated. And also the pulmonary artery. I have seen many case reports where they have done EBUS to document central pulmonary thromboembolism in few cases. So we can visualize the vessels, also search for anything in the vessel that is also important. Second indication for EBUS will be not only the lymph node, any mass lesion around the tracheobronchial tree. It could be a mediastinal cyst, or it could be a central mass, or it can be a mediastinal abscess, or it can be anything around the airway. If you want to visualize, you can visualize it and sample it. So it is not only the nodes, any structure around the tracheobronchial tree we can study and we can sample it.
Thank you, Thomas, sir. So over to Dr. Sanjit Mohan. How do you suggest beginners to learn the art of EBUS?
Thank you, sir. So, answer is, sir, vessels, and vessels. If you have learned the art to identify the vessels, you will automatically identify the nodes. So you should focus mainly on to identify the vessels first. So I'll suggest all the beginners to start using the left hand first. Give pain to your left hand so that you identify all the landmarks, identify all the vessels. Once you have identified the vessels, your work is done. Your complication rates goes very down, and your identification to the lymph node, it is amazing. You can easily diagnose which lymph node, and you'll never mislabel it.
Thank you very much. Over to Dr. Ankit. In difficult anatomy, how do you decide between the diagnostic yield and the procedural safety?
Yes, that is a very important question, sir. If we have to see, we know that anatomy is difficult, the approach is difficult. We have to decide between the yield and versus the safety. So always safety precedes the yield. So incorrect tissue is worse than the no tissue. So we have to definitely see the safety of the patient also. Incorrect tissue also led to the wrong staging, particularly in the case of lung cancer. So there could be, if there's incorrect staging, the surgical prospect could be different, whether to go for a surgery or not to go for a surgery. Decision of the chemoradiation, it depends on the lymph node staging. So that is important. Beside this, suppose there is a complication of vessel puncture, then it can cause catastrophe on your table. It could be airway hemorrhage, you need an emergency intubation and something like that. So if there are difficult stations, definitely the safety of the patient come first.
Fine. Thank you, Ankit. So, Dr. Thomas, sir, are there any indications of intranodal forceps or cryobiopsy in the diagnosis of mediastinal lesions?
The one limitation of EBUS scopy was less tissue, or tissue is the issue. In that case, in between the mediastinoscopy and the conventional EBUS, we have intranodal forceps biopsy or cryobiopsy can be used to get maximum tissue from the node. This is particularly useful in cases of granulomatous disease or lymphoma, where lymph node architecture is more important. And if you want to get more tissue, like in the current era of NGS, targeted therapy and all, you need more tissue so that you can use either intranodal cryo or forceps biopsy. It's also important in scenario where there's a necrotic tissue inside. When you use cryo, you can get a bulk of tissue so that you will not miss the diagnosis. False negativity can be avoided. So I think this is a bridge between the true mediastinoscopy and the conventional FNA. Either you can use the forceps, intranodal forceps or cryo, so that your yield will be better and you'll get sufficient tissue in cases where lymphoma or granulomatous disease is a concern.
Thank you. Thank you very much for your indications of intranodal forceps and cryobiopsy. Thank you, sir. We'll see some of the chat box questions. Dr. Mahendra Singh Raghuvanshi from Madhya Pradesh. So complications and risk due to the EBUS procedures. Already Thomas had mentioned about that. The bleeding is one of the complications. Always we have to use the Doppler. Despite that, some of the bleeding we have to tackle effectively. So we have to have all the backup facilities, ice saline and other methodology we have to use to arrest the other complications. Thank you. And another question from again, Dr. Makesh Kumar Mishra from Rajasthan. Jaipur, how much technically demand at the district headquarters and how long learning curve for surgeon for it? Anybody can take this question. So how much technically demand at district headquarters regarding EBUS procedures? So he's asking like this only, and how long the learning curve for surgeons for it? Anyone? Ankit or Thomas?
Yeah, what they say is at least 25 scopies should be assisted, and another 25 should be done independently to have a good command and to get tissue effectively. So minimum 50 is required for a beginner to reach a level that the test will be possible.
Okay, sir. Yeah, again, Dr. Magesh Mishra is asking questions like, is there any difference in endobronchial size of lymph node and radiological size of lymph node? Ankit? Endobronchial lymph node size and the radiological lymph node size. Is there any difference or any correlations, anything related with that? Sanjit or Ankit?
Not exactly about the size, but maybe the texture could be more defined by EBUS, particularly in that way.
Yeah, okay.
The millimeter size may vary, sir, but mostly it is almost the same. But 1 to 2 mm can vary between the EBUS and the CT. Also, if the CT scan was done 2 to 3 weeks before and we are doing a EBUS now, so now at this point of time, EBUS may show a larger lymph node as compared to the CT scan. So that can be a point.
Okay, fine. Thank you.
Also, I want to add, inflammatory nodes sometimes subside. When we are having a CT of 2 weeks prior, when we do EBUS, we won't find any node. That happens in some cases where there's inflammatory or reactive nodes are there.
Yeah. One more question from Dr. Darshan Kumar Bajaj from Uttar Pradesh, Lucknow. I think even with the combining EBUS and UES, we'll not be able to sample station 6 also. Ankit? The 5 and 6, this is parabatic, subaortic. So
Can't be sampled by EBUS or US.
Yeah.
They require either extended mediastinoscopy or VATS.
Yes.
Sample level 5, level 6.
Fine. And one more question from Dr. Mahesh Manusra from Jaipur. Experience regarding the intranodal biopsy using EBUS. So already Thomas sir explained about that. Okay. Mahesh Kumar, again, question about which company market intranodal biopsy? I think sir is asking about the needle. Which company is manufacturer of this intranodal biopsy forceps? Thomas sir?
Yeah, I think Olympus is marketing it a 1.1 needle, which is a very thin needle, which you can make an opening in the airway by 19 size needle, conventional EBUS needle, make an opening and through which you introduce the 1.1 size dedicated forceps and make sure that you are inside by using the ultrasound probe. Once you are confirmed it, you can open the biopsy forceps and you will get the sample.
Thank you. Thank you very much, sir. So we had a wonderful discussion on the mediastinal tumor for the EBUS operator. We have discussed thoroughly about the mediastinal anatomy, lymph nodal stations, and role of EBUS, role of UVS, and the mediastinoscopy and the video stereoscopic surgery. So wonderful discussion. We have a lot of take-home points. I hope delegates also enjoyed this update, the second webinar on EBUS Part 2 series webinar. So I am requesting all the panelists to give one-line take-home messages to start with Dr. Ankit.
So, sir, vessels are compass, lymph nodes are destination, so never navigate without your compass.
Fine. Dr. Sanjit.
I second with Ankit sir. Vessels, you have to be sure about the vessels and don't just hurry up biopsying or sampling the node. You should be very you should screen for the node when you are confident enough, then go ahead for the sampling the nodes.
Okay, fine, fantastic. Dr. Thomas sir?
Yeah, in EBUS, bleeding is not about luck. It's about preparation, Doppler, and discipline.
Doppler discipline. Fantastic, fantastic. Dr. Mohan Venkatesh Pillai sir, take a messages your side.
So mostly the mediastinal staging, lymph node staging has been is taken away by the pulmonologist. But if you require any help, we are there as surgeons to sample those lymph nodes. Dr. Sanjit.
100%. Finally, Dr. Priya ma'am, your take-home messages as a subject expert.
Surgeons and pulmonologists are like the yin and yang. Yin and yang. So we are the two sides of the same coin. So one cannot do without the other. So I think when we need, you are there. When you need, we are there. As long as the patient goes home safely and we are able to give the best, we both are together. We cannot work without each other. So that is the moral of this story of CCI, I think, always.
Thank you very much for the wonderful take-home messages from all the panelists. So mediastinal anatomy is very, very important. Mediastinal lesion diagnosis and treatment is multidisciplinary. So we have to have the multidisciplinary team approach. We will discuss with the radiologist and the interventional pulmonologist and the thoracic surgeons' expertise in mediastinoscopy and video spectroscopy. So the EBUS, UES, and the mediastinoscopy and VATS all the complement to each other to diagnose early, treat early, to prevent unnecessary morbidity and mortality. So we'll have a very quick diagnosis with advancement of the lot of optics. So EBUS is slowly replacing, I don't know exactly about that, but as of now, the mediastinoscopy is a gold standard to reach wherever level. Otherwise, we can use the video spectroscopic surgery to reach wherever lesions. But 80 to 90% endobronchial ultrasound, so with a convex probe ultrasound, we can reach all the mediastinal lesions except some parayotic, subayotic, and other 11 size node and all. So definitely thoracic surgeons and IP, interventional pulmonologists, so complement to each other to diagnosing these kind of lesions. I thank you all for the wonderful discussion. I thank you once again, Chess Council of India, for giving me this opportunity to moderate this wonderful panelist, Thomas sir, Mohan sir, Sanjit, and Ankit, and Priya ma'am. So we had a lot of take-home points from this today's discussions. So again, the third part of EBUS webinar next Thursday. So I thank our EBUS course directors, Dr. Ravi Doshi and Dr. Jaykumar Mehta, for a wonderful design the course about all the moderators, speakers, what topic and all. I thank once again Krishnaji and our Pradeep sir and our assistant division and the Vijay Kumar Chandram Shetty, Anil Maske, Shivani Swami, Kirat, all the leaders, Dr. Atrik Angopadhyay. I thank you all once again. So we'll meet again next Thursday with our superb part 3 EBUS webinar. So thank you all. Good night. Long live CCI.
Thank you, sir. Good night, sir.
Thank you, sir.